Welcome to The Independent with Scott Atlas by the Independent Institute, my show that tries to bring a uniquely rational perspective to important issues facing our society today. Today's special podcast is a conversation in front of a live audience in Zurich for the Global Liberty Institute's International Rising Leaders Summit with my guest, Sweden's Dr. Anders Tegnell. Anders Tegnell is a physician and epidemiologist who was the state epidemiologist at the Public Health Agency of Sweden. He led Sweden's response during the COVID pandemic, basing Sweden's strategy around maintaining an open society with voluntary guidelines instead of lockdowns, mandates, and school closures. And since then, the world's data proves that Sweden's response was correct, with the smallest rise in excess mortality of all developed nations and avoiding the severe harms, particularly to children, found especially in the United States. Thanks for joining us and stay tuned. Anders is a physician and epidemiologist. He had the title of state epidemiologist at the Public Health Agency of Sweden from 2013 to 2022, and I think everyone knows he led Sweden's sort of unique response during COVID. The data shows that Sweden, despite all the criticism in the U.S. of Sweden and of other countries of Sweden, Sweden actually had the best results as measured by the most important indicator, which is excess mortality. And they did not do strict lockdowns, but instead used relatively voluntary guidelines informing and indeed trusting the public. They did not close their schools at all. And that showed to be not just no harm, but even more sophisticated, nuanced versions of harm, like the data in the psychiatric literature showed that Sweden's teenagers and young adults did not have the harms of the anxiety, depression, suicidal ideation that was experienced by the young people in the rest of the world, particularly in the United States. I'll just say something that I've told him before, which was one of the funniest criticisms of me during the fiasco of 2020 in the U.S. was I was called in an accusatory way the Anders Tegnell of Sweden, and I still wear that as a mark of pride. But with that, I'll introduce for a brief presentation and then some discussion, Anders Tegnell. Please welcome him.
Thanks a lot for the kind words. As I said to somebody here before, one of the perks of being through this and sort of moving from a fairly anonymous working in an agency in Sweden to being infamous in most of the world is that I get to come to this kind of meetings and really learn about things that I find incredibly interesting and really touching on. I mean, public health is very interesting like that because it really touches on any other area you can think about. And then any other area you can think about will also influence public health. So I think these discussions I've heard today are really fascinating. And it's also very nice to be here in front of you, the next generation, because I think sometimes we are not all that good about sort of transferring our knowledge and maybe not always the best knowledge, but at least that we can transfer both what we happen to do well sometimes and where we went wrong to the next generations. And we are not always very good at that. Suddenly people disappear and then somebody else has to step in and doesn't really know very, very much on what happened before. And I think pandemic is a very good example of that. We don't talk very much about the pandemic, at least not in Sweden anymore. And I think we are on the verge of losing a lot of very good, very innovative ideas that we managed to catch during this time. First of all, I think context is incredibly important. And I think many of the talks we have heard today shows that we cannot really do things the same way all over the world. We can have the same goal, we're doing things, but we need to do them according to our context. And that's why you need to really understand and understand your context when you start handling a crisis. Because if you don't, you're going to get lost very quickly. And if you try to introduce new steering mechanisms during a crisis, it's not a very good idea. And Sweden is a very decentralized country in many ways, which I think there's a lot of both strength and other things around this. But it means that a lot of the decisions are taken very close to the population. Because the municipalities in Sweden are very small. I mean, they range from a few thousand people up to 20, 30,000. So they're usually quite close. And they are very independent, and they're they defend their freedom very much, except in a crisis, which is interesting, because then we heard from everybody, we want you to tell us how to do this, because we want to do it the same way, because that's the way we maybe avoid criticism to a certain extent, but we also understand that in a crisis, there's a lot of good things around doing things in a similar manner. And of course, we have a legal framework, but somebody talked about what is Europe really? And many times you tend to look at France. The French legal framework and the Swedish legal framework are vastly different. The legal framework in Sweden is fairly loose. It shows where you're supposed to go, but not how to get there. And I think that's also one of the strengths that in a crisis you have that. And there was a lot of principles that we discussed a lot. I don't know how much it was discussed in other countries. The precautionary principle was taken up all the time. And it was interpreted in many different ways. In some countries, it said it was a precaution to do everything at once very, very quickly. We thought the other way around. Being precautionary is not doing things that you don't feel very good about that is really going to make a difference and make things better. So I think that's was really important to us. And I think that's also in the medical profession, that do no harm is one of the Hippocratic Oath's main principles. And I think that's important. And another thing that's built into many of the Swedish laws is proportionality. You really need to show it before you force people to do something by legal measures, that you cannot do it in a similar way by doing it without forcing people to do it. And then we talked about how do you define a crisis. And I think this is quite tricky when it comes to pandemic and health crisis, because they tend to build up over time. So there's not usually sort of day is a crisis. And I think this timeline, I'm not going to go into any details, but that shows that to a certain extent. There was a couple of months in the beginning when we saw cases coming up all over the world, but we were not really quite sure how this is going to develop. And then when are you going to press the button and say this is a crisis? In the global world right now, WHO can do that to a certain extent, but based on what is still quite vague in many ways. So this was building up over some time, and I think that was also a reason why I think there was possibilities to act a bit more according to the data, because there was a fair amount of data around at the time when the crisis really hit. And in Sweden, I think this was, once again, we come back to context, because different countries were hit differently, and we tend to spend a lot of time comparing each other in the beginning, not thinking about that it really started in many different ways. In Sweden, it started with the spring holidays. We have 3 or 4 weeks in March when all Swedish school children are free, and Swedes then travel. 10% of the Swedish population leaves Sweden during these critical weeks. So we got like 1 million Swedes coming back from all over the world, and still today we don't know how many of them came back with the disease, but quite a lot of them. So we had a massive introduction very, very quickly that changed everything, and all of these things about trying to close borders or test and trace everybody and so on was basically impossible already from the beginning. So we tended to go for a long-term, more resilient answer to this. And what we wanted to do was this kind of classical pandemic strategy that I'm sure Scott and some of you are aware of, but was quickly forgotten. What you actually want to do is to have, you realize you're not going to be able to stop a pandemic, but you don't want to have too many cases at any given time, because then this society will be hurt in many different ways and will actually probably suffer more than from the disease itself. So you try to push down the curve as much as possible. This time there was a lot of discussions around that we might be able to stamp it out. And a number of countries did that more or less openly, but nobody ever managed to do it. I mean, there were places like Australia and New Zealand who managed to keep it out of their borders, but there were very special circumstances around that. So, I mean, this is really what we try to do. So what we try to do is really to find out where do we need to restrict society. Not closing it down completely, but trying to find what are the places where you tend to get infected and try to get less people going there. And trying to use the data continuously to find out, okay, we know that restaurants, for example, might be a tricky place. So we do regulate the restaurants so they don't have too many people at any given time. We know that big concerts and so on might be dangerous, okay, so we don't have big concerts anymore. But we also know that people going outside with their dogs or walking in nature are definitely not at risk at all. So we encourage that instead. So we try to reduce what we call contact intensity as much as possible by a mixture of a few regulations for restaurants and a few other things, but mainly doing voluntary recommendations to the population. So we did a few binding regulations, and not everybody realized that there were actually binding regulations also in Sweden, but these were mainly directed towards companies and stuff like that, who to a certain extent wanted these regulations because that made it possible for them to reclaim some of the losses from the state. So this was very much done in a close collaboration with the companies. But when it comes to the population, we went through these kind of recommendations, and we did it in a number of different ways. Among them, 198 press conferences, which was, I think, a new record for anybody. And I'm still wondering why we stopped at 198 and did not do 200, and then we could have gone to this Guinness Book of Records and so follow up on that. So it was, I mean, this classical communicable disease recommendations, nothing fancy, nothing strange, and quite easy for people to understand, but also making them open enough that you could sort of, okay, you should be as little as possible at your workplace. If you can work from home, you do that. If you can't, at least try to cycle to your work. So this, you, on the individual level, trying to get people to understand this is what we try to achieve. We want you to meet less people every day than you normally do. And you find a way of doing that. If it means that you will stay at home and work from home, or it means that you will cycle to work instead of taking the subway, that's up to you. And that actually did work. And it worked because we also had a massive collaboration with all different parts of Swedish society. I think most of these maybe not be that obvious to you, but it's a mixture of national agencies, voluntary organizations and other things. And we had a huge amount of different organizations who sort of really worked with us in this. So it became a whole society effort to keep this contact intensity as low as possible, but still having people having the possibility to live a good life and a healthy life, because we really encourage people, for example, to go out walking in the forest and so on, to the extent that our national parks contacted us and said, come on, you can't do this to us. Our parks are getting completely overwhelmed. We have to stop telling people to go out like this, because the nature is going to get destroyed in this way. We can't handle this anymore. So it has a number of very interesting effects when you work like that. When it comes to schools, I mean, this was a big discussion in many countries. For us, it was very easy. We could see from the data from China and from Italy and from everybody else that kids did not get sick very often. We also knew, because we have plenty of people in our agency who knows about schools, how incredibly important schools are for health. I mean, this most important thing you can do for anybody in society is to get them through the school system, because that will really determine the rest of their lives to a great extent. So for us, it was never a very big discussion. The teachers were worried, but fortunately we could run the data and show the teachers that they were not at higher risk than anybody else. And when you started looking at it locally, teachers did not get infected for the kids. They got infected when they had coffee together during the traditional Swedish fika. So this is something we're really happy about that we did. I think it's going to make a huge difference for many kids. And we talked about how much are we going to do the same thing next time. I think if one of the things that many people were doubtful about is closing the schools again, because I think the negative effects of that are so obvious, and the positive ones are probably not even there. We even did a study in the Nordic setting where the other countries closed schools, and we tried to see, does this change how many people get infected in society? No, we cannot see any differences. Coming back to where we had a problem, we had a huge problem with the nursing homes. This is from US, just to show that everybody had the same problem, but it was really incredibly big problem in Sweden during the first, especially the first spring. I mean, out of the 2 million people in Sweden that are above 65, 10,000 people live in this society. So it's a very small group, but that small group consisted of 70% of the mortality during the first wave. So this was the one place where we did not manage to protect one of the major risk groups. For the rest of the elderly population, we did reasonably well. We could look at the data and see that they were infected much, much less than other groups of society. But this did not work very well for many different reasons. And the other thing that we did not do very well was to integrate the newcomers to Sweden. This is a bit tricky maybe, but it basically shows that if you live in Sweden and have a background in Africa, your chance of ending up in intensive care is 7 times higher than if you have a background in Sweden. And it's sort of coming from other places. So it does about the same thing. Interesting enough, if you come from North America, you have even lower risk than being in Sweden. So it's different factors behind this. But definitely, and we did not reach this part of the population very well. It's quite a big part of the population. I mean, about 20% of the Swedes today have a background in another country than Sweden. So it's a big part of the population. But just another sign, and there are many signs of that we do not do very well in integration. And then the vaccinations came, which I think we can all be very happy about, and we're very lucky. We need to realize that. Next time we might not have vaccines that quickly. A lot of circumstances worked the right way this time, so we were lucky to have it. And we used it, I would say, very effectively in the Nordic countries, because we went very strongly to the people who were at highest risk very quickly. So we went to the nursing homes very early on, and we had like a 95% coverage in the nursing homes within a month or two. And that made a huge difference. But once again, we had the problem to reach our newcomers, even with the vaccines, even if that worked reasonably well also over time. So people really followed our guidance to a great extent, and we went out and asked them, and like 80% of the population said, okay, yeah, I did change my behavior quite a lot. And the trust in the agency was fairly high already from the beginning, but increased during the pandemic, interesting enough. And people followed the recommendations, and we could see that in different ways. We could use the data from the mobile phone operators, and you see that the strong line here is how much the Swedes changed their travel behaviors compared to the other Nordic countries who had similar data. And actually the Swedes changed their travel behaviors more than people from the other Nordic countries, in spite of our very loose recommendations. And we could also see it on other diseases that are similar to COVID-19, like whooping cough. And whooping cough basically disappeared during the first fall, and it did so in many countries, showing that also in Sweden, people kept the distance much more than they usually do. And then we had a lot of problems with that. We were so much compared to our other Nordic countries, especially in the beginning, because of mortality. It looked much higher than it. And you can obviously see here, not so easy to see, but Sweden is constantly the country that has the highest mortality, depending to a certain extent how we defined that you die in COVID, which is not so easy. But you need to understand your context. And if you compare Sweden to other European countries, we're actually in the middle, the blue line here, and many of the other European countries much worse. So once again, you need to understand your context and what you compare to. And Sweden, in many ways, have more similarities to countries like the Netherlands and Austria than we have to Finland and Norway, in spite of us speaking similar languages. And then, as Scott was said, in the end, we tried to look at the excess mortality. And here I've taken one calculation where Sweden ends up being the 4th or 5th lowest. I mean, other calculations, Sweden is definitely the lowest in Europe and so on. So for the whole period, Sweden ended up doing quite well in spite of many of these things. And I think that's quite interesting. So we did a lot of things. We did not just sit around waiting for things to happen, but we did them more focused than many other countries. And we did really focus on trying to avoid severe disease and death as much as possible. We saw an increase in health inequalities in Sweden as in many other countries, especially when it comes to our newcomers and the socioeconomically less able. And then the question will always be, what's going to happen next? And this is from one of my UK colleagues. We got it during the swine flu pandemic. And I think one of the interesting things is, even if you keep on guessing, sometimes you guess right, because it ended up on monkeypox. And 10 years ago when I got this, monkeypox was a no-brainer. Will never happens. So even when you're guessing, you might be right. Thanks a lot.
We'll take a few minutes to chat with some discussion and then open it up for the floor. I just taking notes on what you were saying and having spoken with you before, there's certain principles that stand out as being very different from particularly the United States, but most of the rest of the world that you used. One was simply do no harm. Okay, you said, you focused from the beginning on minimizing collateral damage, and this was completely lost in the U.S. and many, many other countries. You told people, you use common sense. You told people go outside because you don't have to, none of the stuff as we've spoken is very complicated science. I mean, this is sort of common sense. Yet in places like San Diego, the Coast Guard was going out and arresting people that were surfing. We had people being arrested on the beaches in California. He said you use classical recommendations because there are other viral respiratory, there's a whole body of evidence on viral respiratory infections that was abandoned. And then finally, schools. You said that your society recommended, knew that kids had low risk. That's what the data showed for serious illness. And there was a societal understanding of how important in-person schools were. And I'm just wondering, these things are so obvious. They were obvious to me, but I was talking to myself half the time in the U.S. I was just, why is it in your view of things that Sweden saw these things? Was it just you personally, or was it the public? In other countries, they just didn't see it this way.
I think it's not always easy to understand yourself why things happen like that. I think one thing was that we have the broad responsibility for public health in our agency. So we did not just look at communicable diseases. We all the time worked on keeping the population as healthy as possible. And that was our mandate, and that's what we always worked. So this thing about looking at collateral damage and so on came back to us all the time. So, and we had a lot of discussion around the schools before, because schools in Sweden tend to not work as well as they used to do. So the whole schooling things, and we had a lot of discussions together with the school authorities and school experts and so on. So already before this, we had a lot of focus on the schools and how important schools are for children. And we can actually show in Sweden that if you only have basic schooling compared to if you have an academic degree, it means 7 years in life expectancy, which is much bigger than the difference between men and women these days. So this really shows where they need to put an effort. So that, I think, meant in the end we were always going to want the schools to keep on working. And we had really the school authorities and everybody behind us. And we also had the politicians behind that. And you need to remember that there was no political opposition to what we were doing. Rather the opposite, they were very much behind us.
Yeah, this is sort of very interesting to me, was that while you might have been attacked in the U.S. and in other media, you've said to me before that you didn't get that much pushback inside Sweden.
No, definitely not from the political side, not even from the opposition. Towards the end, there were some things from the opposition, but then we were closing to a new election, and I think they really want to show that the previous government was no good. It didn't matter. So, and for the population, definitely nothing at all. There was a small group of academia who wanted us to do more. A little bit unsure on what more, but just do more. And there was a lot of anxiety, I think, in that group. So, no, I mean...
Although there was some pushback in academia, I mean, I think people in medicine remember that the Karolinska researcher that published an article in the New England Journal saying that, well, this is actually the data. We didn't close schools at all, and it wasn't the problem. I'm simplifying, but basically 0 children died. There was nothing going on, and he was vilified.
Yeah.
But and he ended up, his reaction was, okay, I'm done doing COVID research, which is a real shame. What was happening then in the academic circles? And were you sort of related to that, sort of insulated from, were you not viewed as part of academia? You were part of sort of government. I mean, how did that dynamic work?
No, I mean, I think that dynamic is maybe slightly different than in other countries. I mean, the agencies in Sweden work a lot with academia, but we are actually translators of what academia produces to the government, since the government doesn't really have any, I mean, there's no medical people in government and so on. So the government is very dependent, and that's how the system is built up. Everybody's very happy with that, that the agencies where many people have academic background, I mean, I think we are among the people working in our agency, 60-70% have a PhD. So it's not that we don't know about it, but our main purpose is not to do research ourselves, but mainly to translate research into policy advice to our government. So this was, to a certain extent we were isolated from academia, but we kept on having a lot of dialogue with them, of course. But I think we were seen by everybody not as part of government, as you said, not part of academia.
What was your reaction to what was going on, if you remember, with the sort of frenzy and the media? I feel is quite vicious in the U.S. and elsewhere. Was this something that was shocking to you to see how we and other countries were reacting to your advice, or did you just not pay attention or weren't aware of it?
No, I was certainly aware of it, and other people told me about it, even if I didn't follow it so much myself. I think the reason why I didn't think, or we didn't think, because we're a whole group of us, that it was very important, because many times when we talk to the experts in the different countries, they could tell us on the telephone line and so on, I think you're probably doing the right thing. We are not too happy about what we are doing here, but we cannot do very much about it, but we follow you with interest, and most likely you're doing basically the right thing. And that's really made it possible for us to continue, because we really felt that there are many knowledgeable people in the world who actually think like us. And I think you said a very good thing in the beginning. I mean, this is seen as a completely new disease, but it's not really. I mean, it's another viral respiratory disease, and we know quite a lot of them, and we know that can vary, but they vary not to just anything. I mean, they are reasonably constant. So to say that we knew nothing is not right.
Right. I mean, this whole concept that was part of inducing fear was to say this was the novel coronavirus, and this newness was as if we knew nothing about anything, including other coronaviruses or basic biology, all kinds of things that it was very difficult to fight off. I mean, I still don't understand how much, if anything, was political in the beginning, particularly in the U.S. during a campaign season, but obviously worldwide it wasn't due to that. It was something else.
Yeah.
What did you feel that Sweden's population was extremely fearful, or what was the general mood of the public?
No, I think they were less fearful than many other countries. I had some interesting meeting with the Nordic Council afterwards, who went around to the different countries to discuss and follow up on the pandemic. And their distinct impression was that people were a lot less fearful in Sweden than they were like in Norway, Finland, and Denmark. And probably because our message was different. We can handle this if we work together. And sometimes when I come out and talk about this, they say that the difference in Sweden was maybe partly because we talk to the population like they were adults, not children that you need to sort of tell, don't go there because you're going to get hurt. Instead of
to me, this is one of the most fundamental lessons from COVID. And in fact, is completely contrary to what I saw in Washington at one of the task force meetings. And I've written about this publicly. It's not news, but I can't get out of my head that I was sitting across from Anthony Fauci, and this was in August of 2020. And he looked at me and he said, one of the biggest problems is the American public is not afraid enough. And I said, I just sort of said, can you just repeat that? This is at a task force meeting. And he said it again. And I mean, this is completely unethical way to do public health.
Yeah, and it's not very effective. We know that because people who are afraid, they don't do logical things.
Right.
But if they have good information, good knowledge, I mean, people are not stupid. They can sort of understand, okay.
It seems so easy listening to him. It's as if, and this was so obvious, which I actually thought was one of the frustrations for those of us who also thought it was obvious on what to do. But that's not how the world was reacting. Are there any questions for Anders?
Yeah, Doctor, I'm curious to what degree you think the experience of Sweden can be generalized to other countries. Sweden is, I would remark, an ethically homogenous nation state with very high levels of social trust. And as you mentioned, people who are largely due to their own choices don't integrate well into Swedish society, did not experience the same sort of reduced impact from COVID that the general population did. What lessons would you say there are for a country like the United States where we have sort of degraded trust in our social institutions?
Yeah, I mean, it's often mentioned that this cannot be done anywhere else. I'm not completely sure because people are not stupid in other countries either. And if you give them reasonably good information, I mean, you can expect at least some part of also understanding and trying to do that. But I think the main lesson is really what I said in the beginning, context. You need to understand that during a complicated crisis like this, you cannot do the same thing all over the place. And you need to, and I think what we failed in the beginning was to use the data to really understand what are the danger spots, what are the hot spots, so we don't go around and close everything down. And that's really what we tried to do in Sweden. We did several studies and tried to understand what are the hot spots. And we could, for example, find out that the gyms, everybody thought it's a dangerous place. We could find out by looking at the data, no, it's not. And we could also see that almost 40% of everybody gets infected in their workplace. So we tried to get people to stay away from their workplace as much as possible. I think those kind of things we need to do much better next time. And they're obviously going to be different in different countries. I mean,
I think the nursing home was a big failure in Stockholm, particularly. Yep. But that was shared by everywhere. But I do want to sort of interrupt and say that it's a false narrative to say, oh, it's only Sweden. It can't be applied elsewhere. And in fact, there's good application directly to the state of Michigan in the United States, which had the same sort of seasonal weather pattern, the same kind of there's only a slight difference in when you compensate for risk factors for COVID in terms of the health population. There's still a massive difference in outcome, and it was you can't do a perfectly controlled experiment, but it's relatively speaking there is a direct comparison that's able to be made, and I think part of it is not just on the outcome, but also on the mandates and the need for mandate. And when you use mandates, you incite fear and things like that. It's very difficult to tweeze out everything. That's a point well taken, but some things can be tweezed up. I want to mention something else, which is a hot topic, of course, everywhere, but particularly in the U.S., was the idea of the vaccine, the COVID vaccine. And you mentioned in very glowing terms about the success of the COVID vaccine in 2020 in the nursing homes particularly. And there's a couple of points I want to add to that. One is that the Biden administration allocated vaccines, and it was partly controlled by the governors, instead of the high-risk people. The priorities were not the high-risk people. The priorities were people in hospital settings, Many of them are very young and healthy and were not high risk. In fact, I had to personally fly my 96-year-old mother-in-law from Chicago to Florida to get the vaccine. And the second part of it is that it is difficult. You're considered now a dissonant voice in the U.S. to say that the vaccines were effective early on, because the COVID vaccine was effective early on. That's the data. And I know there's this big push to say everything about the COVID vaccine was bad, but that's actually not true. Early on, when the virus was in its most lethal form, and when you look at lives saved in the highest risk population, which was the nursing home and elderly, the U.S. data shows it, but I like to look at non-U.S. data because the trust has been lost in the U.S. You look at Sweden, and actually a lot of lives were saved in the most lethal form of the virus variant early on in the high-risk population. Despite all the downsides of the vaccines, despite the misuse of vaccines in young people, the bad recommendations for people who didn't need the vaccine, and the harms that were never really compiled in a very detailed way about the vaccines. There was a lot of malfeasance, but that one point is still true.
We could also see the ICU usage went down. I mean, the third wave in the spring of 2021, we had a lot of infection in society, but comparatively very few people who needed ICU treatment. So sure, I mean, it was not as effective as we would have liked the vaccine to be if you compare to the measles vaccine, for example. But it was definitely a vaccine that saved a lot of lives and also saved, I think, health systems.
And by the way, the vaccine benefit was a personal benefit. It was not a benefit to stop the spread to others, but it did protect high-risk people, lives early on. And so to think in terms of the context of mandating a vaccine, it doesn't logically, to me, make sense to mandate a vaccine that's only going to benefit the people who use the vaccine. It wasn't a public benefit. It was a private benefit. So there's two different things to talk about or think about in terms of the COVID vaccine story. That is, developing a vaccine is very different from mandating a vaccine.
Thank you so much for the talk, Dr. Tegnell. It was incredibly interesting. I have a question that I'm not sure if there's enough published data on to necessarily answer super clearly, but I'm curious nonetheless what your opinion is. You put up a graph that showed the excess, I think the cumulative excess mortality of a bunch of different countries over 2020 to 2021. But if you look at if you include even some of the later years, 2022, 2023, in that, so say a 4-year or 3 or 4-year period, you see like Sweden pulls out even further ahead of most countries.
Including the other Nordic countries, by the way.
And I wonder if you have an explanation for that, or do you think potentially it could have been your more voluntary approach that might have contributed to that, or some other reason?
I think there are different theories around that. I mean, to a certain extent, it's maybe due to kind of harvest effect that sometimes talked about. And you can see that when you have a very grave health crisis, a lot of old people die. During the next health crisis, you get, of course, a lot less people dying because the most vulnerable ones have already died before. And that might be a reason why the other Nordic countries who managed to protect their elderly a little bit better during the first wave, they had more elderly people that were vulnerable during later on. I think a little bit of that. But I think another reason behind this that changes that it seems like Sweden managed to deliver healthcare on a broader base better than many other countries, because excess mortality stayed in a number of countries like France and the UK, even after the COVID went away. And to me, that signals that somehow they did not treat their chronic diseases as well as they should have. And Swedish healthcare managed to do that to a greater extent than many others. I mean, we had data, for example, on cancer prevention and cancer in different ways like that. And those programs went on I mean, screening for breast cancer, screening for other cancers, stayed at a reasonably high level all through the pandemic, which is not true in some other countries. And of course, that will also, I mean, you need to realize that excess mortality is not only the people dying from COVID, it's also the people dying from effects of the pandemic, like less good healthcare and stuff like that.
I mean, I think this is very important. The partly to answer the previous question too, the comparisons are able to be made because you're comparing excess mortality increase for that country over that period of time. That's an internally controlled experiment. But the second part, and this relates again to the vaccine debate, is that the excess mortality is not due to COVID or not necessarily due to the vaccine killing people, for instance. Excess mortality is from the management of the lockdown. Okay, millions of people died from the lockdown. The severe economic downturn killed people. And this is known. This has been known for decades that the severe economic lockdown or shutdown would kill people. And it's also true that the mismanagement was so shockingly bad that the recommendations were to keep people in their homes. You notice Sweden said go to the parks. Okay, in the United States, keep people in your home. Well, that's where all the cases spread. You were literally killing people from COVID with the management. But the later years, the 3 to 4 year period of excess mortality increase, we see still destruction from the lockdown, from as he said, something like more than half of chemotherapy patients with known cancer in the United States were so afraid, they were made afraid to go in, they didn't get their chemo. 75%, 85% actually of living organ transplants were not done in the United States because people were afraid to get their transplant. They thought that the hospital was dangerous because of COVID. And this went on and on. The cancer screening data is now coming into play. People didn't get screened. If the cancers didn't go away, the cancers now present in a much later, more advanced, a more widespread form in people later. They're going to die. And so the management of COVID killed people in the United States.
Dr. Tegnell, we did a couple of interviews together during that period. I want to ask a question from the other side, which is, do you think you could have done even less? I mean, in retrospect, there was still a lot of measures which were very damaging to the economy. You showed us the Google mobility data. Sweden, people weren't moving around. Universities were closed. People were sent home. I remember that the curve was remarkably similar in Sweden to the United Kingdom, which had draconian lockdowns the spring, then it ebbed away in the summer, came back in the winter. How do we know that you couldn't have even done much less than even you did and had an even better result?
No, I think you're right. I mean, there are things that we did that I would not do again. I mean, we had a ban on visits to nursing homes. This was not a good idea. We could easily show that it was not the visitors that took the disease into the nursing home. It was the staff, and it not pointing to giving them any, showing that they are bad people and they didn't have the knowledge, they didn't have the equipment and so on to stop that. But in practice, visiting nursing homes was not a danger. And I think if it's one thing I don't feel good about it, this was highly unethical. I mean, these are elderly people. They should really be allowed to make their own decisions, what kind of risk they want to take and don't take. We managed to stop it after the first spring, but it took a lot of effort and there was a lot of opposition to it, both from the nursing home, but also from a political level. But in the end, we managed to get a process into place that the nursing home had to apply if they wanted to close for visitors. And then they had to show that there was a real risk and they couldn't manage it. And then no nursing home had bans on visitors anymore because nobody could show that. So, and at universities, I think we could have been more open to that. They could have been there more than they're being and so on. So, yes, even in Sweden. Partly because the legal system we used to close certain things down, like big events and so on, were the legal system we had in place already. And that didn't make it possible for us to make a distinction between church services and a concert. We needed to close them down, all of them at the same level of people. And of course, I mean, in a big church in Sweden, you could have more than 5 people coming there without any risk at all, why you maybe didn't want to have a concert going at all. So, and this is what we're trying to rectify now afterwards, so we can have a more focused legal system, that we don't need to close everything down at the same level, but to close down more according to risk in different places. So sure, I mean, we are also learning for sure.
So you said that the decisions that you made were sort of obvious based off the statistics from, early cases. So I wonder, why would the other health organizations not make similar decisions from your perspective? Is there something about Sweden's government that has the Swedish officials like less power hungry, or they don't have other incentives or motivations behind decisions they're making?
I think there's a mixture of answers to that. To a certain extent, it was not the health organizations that took these decisions in most places, it was the political level. In Sweden, that's not usually the case, because we have another division of labor or mandate between the political level and the agency level, where the agency have a mandate to do a lot more than they do in other countries, which also means that the Swedish government has very small departments and no technical people at all. The people working there are policy advice people who listen to their agencies and so on, and then translate that into policy advice for their politicians. So I think that made it a bit easier to actually follow the data. And also that there's a lot of trust in the Swedish society. We talked about that between the government and the population, agency and the population. But there is also a lot of trust between the government and its agencies. So we had been working together with different politicians, and I've been working with politicians from all different kind of political parties over the years. And generally in government, they really trust their agencies to come to them with good advice. So it takes a lot of incentives and a lot of other signals for Swedish politicians to go against what the agency is advising them to do. And to a certain extent, it's even not legal for them to go against, because then you are overstepping your own mandate, and they could be taken to constitutional court if they try to start taking decisions that are mandated to the agency. So it's different systems. And of course, to a certain extent, it was also a personal kind of system, because, I mean, the politicians that were in place had been in place for a number of years already, and we knew each other fairly well. In a small country, that we shouldn't overlook that persons are also, even any kind of system you have can be overrun. But when you have a personal relation and a personal trust, it's much easier to stick with what you usually do.
So thank you that I can ask a question. It's about the pressure from other countries, because in Switzerland we had the ski resorts open, and it came to the silly point that even the German Chancellor Angela Merkel said her opinion that Swiss ski resorts should close because the one in Germany were closed. And so my question is, how big was the pressure from other European countries to be more restrictive, and how did you cope with this?
We also kept the ski resorts open.
Good. That's good.
We felt that if there is anywhere there's a very low risk of being infected, is in a ski resort when you're out on the piste. And the bar afterwards is a different thing. I mean, we all know about Ischgl. So bars are definitely a risk, but ski resorts, I don't know. I mean, this was mostly political, and our politicians, at least what they told us, were quite happy about defending what we did, using the kind of arguments they got from us. I don't know if this is true, but I have a certain feeling that Sweden is, to a certain degree, a bit resistant to that. I mean, Sweden really feels that we know best ourselves, which not always is a good thing to do, but in this instance, it sort of served us.
Okay, I think, is there another question, or? Okay, I think we're going to end the discussion. It was a great honor to have you here, and thank you, Anders Tegnell. Thank you for listening to The Independent with Scott Atlas. If you want to find out more about today's guest, Dr. Anders Tegnell of Sweden, watch for his interviews and expert commentary, particularly about the pandemic and public health in the news. Don't forget to subscribe to this show on YouTube, as well as Spotify, Apple, and anywhere else you're listening to podcasts today, and I'll see you next time.